new independent living residents a chance to try out our community and everything that Hunters Woods at Trails Edge has to offer, and do it before making that commitment. So we're offering our winter staycation where new independent living residents can move into Hunters Woods at Trails Edge. They receive all the benefits of our regular residents, including dinner every night, housekeeping every week, all of our amenities and our activities. And they don't pay until April 1st. So that's pretty incredible, and I think unheard of. And so what we're asking is anyone who takes advantage and say they move in January 1st, they can live in our community for 3 months. And then by March 1st, we want them to give us a decision, either to sign a contract to start paying April 1st and become a full-time resident. And if that is done by March 1st, we will waive their community fee.
Great.
Or if they decide Hunters Woods at Trails Edge is not for them for any reason, by March 1st, they give us a 30-day written notice to vacate before April 1st, and they owe us nothing. So there's truly no strings attached. There's no back pay. There's no long-term commitment, because any of our residents can end a contract with a 30-day written notice. So it's really a wonderful opportunity for seniors to try out senior living before they need to sell their house, before they need to make a commitment.
Or or shovel snow the next time,
Right.
you know, so that's great. Okay. I think you got some other programs you wanted to share.
We do. We have, and let me see if I can.
Just click that tab right next to, it says basic pricing at the top.
I'm not sure I've got that. Let's see.
No, it's already there. Like,
oh, here we go.
Yeah,
there we go.
Go to the top of your screen. There you go. Okay.
You see it? So,
Yep. Yeah.
So our other promotions, we have a promotion for assisted living. Again, really incredible. We're offering our studio apartment and our 1-bedroom apartment in assisted living for an incredible discount of up to $2,300 off our regular price. And that is our December promotion. So anyone who takes advantage of that during the month of December, they will have that discounted price up to $2,300 off. And that discount lasts for as long as they live in the apartment. So it could be 1 year, it could be 10 years. And that's one thing that makes this promotion different than any that I've heard of.
Okay, great. What
we'll
else do you
also
have?
waive the community fee for them.
Okay.
We have our memory care, which is our Life Stories memory care promotion. And we are offering through December an all-inclusive rate, including level of care, medication management, absolutely everything included, for $6,500 a month.
That's good pricing for memory care. So
yes. Also, with all of these promotions, it gives our seniors an opportunity to come into a senior living community and be among the first to receive their vaccinations for COVID. So an additional value there.
Excellent. Well, this is great, Sherry. What I would say is, if you can drop your contact into the chat, and then I just got these 2 flyers. I will make sure that gets emailed out to all the attendees today. And again, I really want to thank you for your support with this month's digital discussions.
Thank you, Steve.
All right, great.
We appreciate it. Love working with you.
You bet. Okay. All right. So thanks, Hunters Woods at Trails Edge, for your support. And let's jump into our discussion with Dr. DeYoung now. So I'm going to bring Dr. DeYoung on. And for those of you who may not be familiar with Dr. DeYoung, he is the Chief of Geriatrics at Capital Caring Health. And I have to say, I've been absolutely blown away at the innovative, outside of the box things that Capital Caring Health has been doing over the last few years. The last discussion that we had with a team member from Capital Caring Health was we had a panel on diversity, equity, and inclusion, and they've created a center for diversity, equity, and inclusion at Capital Caring Health, which is great, but that's just the tip of the iceberg. Dr. DeYoung, welcome.
Thank you, Steve. Can I share my screen with you?
Absolutely. And you know, before we jump into your presentation, those that don't know you, I would love for them to get an opportunity to sort of learn a little bit more about you. Can you just share the story about the journey of your career and
Sure.
where and how you led to leading this some innovative programs there at Capital Caring Health?
Sure. Thanks, Steve. Hi, everybody. So I'm Eric DeYoung. I'm a geriatrician trained in internal medicine, primary care up in Baltimore. And I actually learned about house calls, which has been a big part of my career in East Baltimore, kind of Highlandtown, Dundalk, where I did that as resident. And then I did a fellowship in both geriatrics at Hopkins, but also health policy at Georgetown. So I'm interested in kind of primary care of elders at home, but also kind of the policy and systems that can support us, you know, giving more support to more people. So I spent about 20 years at Washington Hospital Center in DC, running geriatrics there. Really loved that experience. And then about a year and a half ago, Steve, I moved to Capital Caring Health to help build geriatric services and elder care for kind of Northern Virginia, DC, and Maryland. That's kind of the mission that we have at Capital Caring Health. Many of you know it, but just to give a little background, Capital Caring Health is a nonprofit provider for advanced illness, patients with advanced illness, both primary care, geriatrics, and palliative care, and hospice. One of the first hospices in the United States back in the late 1970s, but now really committed to a full array of services for folks with advanced illness. I've been in the DC area for about 21 years now. And I think my task today is I'm going to try to cover a few things, but I'd like to, one, encourage everyone to ask questions as we go along. Please do that into the Q&A section, and Steve can help moderate. I'm going to talk a bit about the COVID-19 pandemic and the new vaccines. I'm going to talk about our primary care at home service. And I'm going to talk about a new Medicare program called Direct Contracting, which Capital Caring Health is participating in, that I think will really help expand the access to good primary care for high needs elders.
I love it. All right. Well, Dr. DeYoung, thanks so much. I'm going to drop off the screen here. And yeah, as you had said, if we get some relevant questions that come in, and folks feel free to type away, I'll just break in and share them with you. But really excited to hear what you have to say today.
Great. So kind of just the basic outline of what I'll touch on is a bit about COVID-19, kind of the latest on transmission, diagnosis, some treatment, and spend a little bit more time on the exciting news about the vaccines. And I'll still talk about prevention, because even if the vaccine is starting to roll out, that's not going to prevent illness in many people who don't get the vaccine yet for a few months. Primary care at home is a service of geriatrics we have at Capital Caring Health. I'll give a bit of an update on that, and then talk about this new model in Medicare called Direct Contracting, which is really focused on improving care for high needs elders. And then again, Q&A, I'd like to do this as we go along, but also have some time at the end. Okay, I'm going to start out with the case. This is an 83-year-old woman who had some just weakness generalized and a fall. So she went to the ER and had a wrist fracture. But they also noticed she had a mild cough, and a loss of smell. So her COVID-19 test in the ER came back positive. She went home, but then 2 days later, into the course of her illness, she had a fever and was short of breath and went back to the ER and was admitted to the hospital. Of note, she lives with an 85-year-old husband who has lung disease. She visits her children weekly and does some communal dining in her senior community. She tries to wear a mask, quote, most of the time. So let's talk about transmission. There's been a lot of change actually in how we think about transmission of COVID-19 since it started last February in the United States. In February, it was largely thought, based on history of the flu and other viral illnesses, that it was mostly transmitted by symptomatic people. So people who were coughing and sneezing and you didn't want to be around them, kind of large particles of kind of infectious disease, kind of mucus that people might transfer. Hand to mouth was very thought to be the way, you kind of get it on your hands from surfaces, you transfer it to your mouth or nose and you get ill. Any type of crowds were of concern. And there was a lot of talk about surfaces and planes being potentially a source of transmission. But things have changed over the last 10 months now. So this is, as of kind of end of November, the literature and the evidence is that this can be transferred by asymptomatic or symptomatic people, which is partly why it has kind of gotten out of control, because people don't realize they're sick. It requires close contact, probably greater than 15 minutes in a day with unprotected contact. It can be transferred by aerosols, and this is really different from not any other illness, but many other common colds or even the flu, that you can be just in the same room. If it's closed, if it's crowded, and even if you're just talking or singing or coughing, you can communicate this illness. Outdoors is actually been found to be quite safe. And surfaces, more and more evidence is coming in that there is no documented risk that I have seen or read where surfaces are a significant source of transmission. So this really requires close person-to-person contact, being in a closed space, indoors usually, that's crowded or where there's a lot of kind of breathing or singing or talking of close contact. Planes are not zero risk, but they are significantly lower risk than what was expected. The ventilation is extraordinarily good, actually, and most kind of carriers, they kind of transfer the air in and out. 99.9% of the air is transferred every 2 to 3 minutes. So you get fresh air circulating constantly. And masks are, as long as there's uniform mask usage, there's actually a very relatively low risk of flying. Doesn't mean it's zero, but it is quite low. So the next question is, how do you diagnose this illness, and when do you want to test? So the classic symptoms you all have heard about are fever, cough, headache, this loss of smell, aches, and even GI symptoms like upset stomach or diarrhea. But in elders, it often just presents as generalized weakness, maybe decreased oral intake, and change in mental status. That means you have to have a really high level of suspicion for the illness, because elders may not present with the classic symptoms. Again, to test, if you have symptoms of any sort like this, you would want to think about a test. But you also want to test if you've had close contact with a positive case. So again, that's close physical contact, unprotected, without a mask, 15 minutes or more in 24 hours. The good news on this is that masks work. Masks, both in the medical environment and in the community environment, have been shown over and over again to have a high level of protection. So if you wore a mask, especially if you were more than 6 feet away and had brief contact, that is not an indication for a test. And finally, the other group that are often tested are residents or staff in high-risk settings. So folks in the nursing home, dementia-assisted living, where people don't realize they need to wear a mask. It's very hard to control folks with dementia and have a mask stay on. Personal care aides who are spending a lot of hours with these patients in their homes or in the senior communities. And the frequency of testing really depends on how high the test positive rate is in your area and how high risk the setting is. Let's talk briefly about the clinical disease. What's, again, very different about COVID-19 than many other illnesses is that it can be contagious when there's no symptoms, and it often does not ever have symptoms. So you kind of are a carrier of the disease as opposed to actively symptomatic. About 40% of folks who are positive do not have symptoms at any point. 50% might have mild to moderate symptoms, and then there's a subgroup who have severe symptoms requiring hospitalization. That's the low oxygen, respiratory distress, even the ICU and on a ventilator. The incubation, which is the time for you to kind of get sick after you've been exposed, is about 5 to 10 days. So that's why you have to kind of go 5 days before you had symptoms and kind of see where you may have contracted the illness, because it can take 5 to 10 days to become symptomatic. And when is it contagious? The peak of being contagious, interestingly, is 2 days before symptoms even start, where you're about to get sick, and then the first 2 days of having symptoms. Contagiousness really declines substantially, and now CDC has, and many scientific papers have shown 10 days after symptoms start or from a positive test, people are no longer contagious if they've had either mild or moderate disease or no symptoms. If you've had severe disease with a heavy burden of virus and very sick, there have been a small number of cases where it's contagious 10 to 20 days, but the guideline right now is 10 days after symptoms start is when people can be contagious. What makes people more sick? So the severity of illness, some people don't get sick at all. Some people have mild symptoms. Most have mild or moderate symptoms, and then a small number have very severe symptoms. So who gets really severe illness? It depends on three main areas. One is the virus dose. If you get a big dose of the virus, you're more likely to get really sick. So that's if you have prolonged indoor contact with no mask, very close contact, like spouses actually often are the highest risk for transmitting the illness within a household because they have the closest contact. And what stage of disease that person is at. If they're at the peak of their contagiousness, you might get a higher dose of virus. So virus dose is number one. The risks of the patient, so their age, heart and lung disease, and obesity are the three big ones. People over age of 80, people with heart and lung disease, and overweight folks have the highest risk of severe disease or death. And finally, socioeconomic status. There was a lot of reports about how Black, Latino, Native Americans have higher risk of the disease and of death. But there's been recent studies that show that while that's true, it's not related to intrinsic race differences. It's related to their socioeconomic status, that poverty, crowded conditions, less access to good medical care are the reasons for those higher severity in those groups, and not because being Black, Latino, or Native American mean you automatically are going to get more sick. So the death rate is really wide ranging. It can range from 0.1% chance of death if you're a young, healthy person without these risk factors to 30 to 40% chance of death. The rate of mortality in nursing homes has been in the ballpark of 30 to 40% throughout the country in the COVID-19 outbreaks in nursing homes. I'm going to stop there, Steve, and just see, are there any questions that we should?
Yeah, actually, thanks. Bree Baldwin actually has a really good question. I hadn't thought of this, but it's great. Loss of smell and taste as symptoms of COVID. Many of our senior patients and clients have lost their senses due to age or medication and cannot speak to whether they can smell or taste. Is there a way that we can assess whether they have lost these senses due to COVID?
Right, so it's a great question because for a couple of reasons, they might have diminished taste and smell over time because of aging, and they might have dementia, so it might be hard for them to articulate or communicate their change. So the best thing I would say in that case is that the history of the symptom is the most important thing. If it is a recent development, that's kind of new, if the nursing staff or the family really notice they're having difficulty with eating or loss of interest in eating, that's new, that would suggest it's potentially an acute infectious process. If they've had this kind of symptoms, or usually it's the aide or the family can tell you that it's not new, then it'd be less likely to be from COVID-19. But it's a bit of a black box in those situations. It's hard to know if it's related to COVID-19 or to chronic aging issues.
Okay, great. And then Lynn Reed asks, When does testing reflect if you are really positive or not? For example, you can have COVID, but testing shows you as negative, yet if you were tested 2 to 3 days later, test would have shown you positive.
Yeah, it's a great question. And, the example that a lot of folks look at is, the White House super spreader event that happened in October, right? A lot of those folks were getting tested with the rapid antigen test, and it turned out to be negative, but they had the virus. The rapid antigen test looks for small protein fragments that are kind of a result of the mRNA virus producing protein, and it can have what's called false negatives. So there's about a 5 to 10% chance of that test being a false negative, where if you did a PCR test, and that's the more accurate test, where it measures for the mRNA of that virus in your system, which reflects more of the contagiousness, and that test is more the gold standard. So that's the false negative. The other issue, though, however, is people can stay with a positive test by PCR, looking for the mRNA. They can stay positive for weeks, even though they're not contagious anymore. So you can have small amounts of the fragments of the mRNA in your nose or your system, and you can test positive even though you're 10 to 14 days after the disease and you're not contagious. And that's why CDC has changed to not using testing as the way of deciding if you're sick or not, or if you're contagious or not. It's really a matter of documenting the symptoms. If you have a positive test, you have to be isolated for 10 days. And after that, you're not contagious anymore. So testing is helpful, but it's not the kind of gold standard for deciding if you have the disease.
Okay, and then question from Tiffany, is PCR a blood test or a nasal swab?
Yeah, PCR is a nasal or oral swab. And that is that's the gold standard for detecting the mRNA virus in your nose or your throat. The blood test is the antibody test. That shows that at some point in the past, more than 2 weeks before, you've been exposed to the virus, you had the virus, and maybe you never got a test for it. And it's called the IgG antibody, which comes after about 2 weeks of exposure. But that doesn't mean you're sick. It just means your body has reacted with antibodies to the virus.
Great. All right. Well, thanks for those questions. Keep them coming in. And if you want to keep on going, we'll hit you with another group.
So this is kind of a sobering, I'm going to pull this down a little bit. This is a sobering table, and this is the stats as of today in the United States and in the world, but mainly in the United States. So I'm going to just walk you through this table. So I have the 4 columns. The test positive rate is column 2, which we'll talk about. And you've heard that a lot, but it basically means the number of positive tests out of the total done. So if you did 100 tests and you had 12 that were positive, the positivity rate would be 12%. And the goal to try to get the pandemic under control is to have the positivity rate be less than 3% or less than 5%. And right now in the United States, we're at a 12% test positivity rate, which means it's still growing. There's still kind of an exponential growth of the virus in the country. Number of daily cases is the next column. As of today, the average 7-day average is close to 200,000 cases per day. So we've added, 1 million cases virtually just about in the past week. In July, by contrast, we were getting 40,000 cases per day. So the epidemic has quintupled on daily cases since July. And in July, testing was fairly widespread. So it's not just a matter of doing more testing. The total cases yesterday was the highest ever recorded in the United States. It was 247,000 people were diagnosed yesterday with positive COVID-19. So pretty sobering numbers in terms of our inability to control this virus, because I think of an inconsistent use of safety precautions. The total cases in the country, as of today, are probably, as of right now, it was like 16.9 million last night. It probably just hit 17 million in the middle of the day today. By contrast, the number 2 country in the world is India with 10 million cases. The number of people in the hospital today is 113,000 in the United States. That is an all-time record for people actively in the hospital. even much worse than what was happening last April in New York City and across the country. And finally, on the far right, the number of deaths. We're at 308,000 deaths as of today. The number 2 country in the world is Brazil, 184,000. And as of yesterday, it was the highest day worst day of mortality for the country in the pandemic. 3,600 people died yesterday in the United States. So you may have seen some of these comparisons. That's more people than died at Pearl Harbor in the Pearl Harbor attacks. It's more people that died in 9/11 on one day. It is an extraordinary kind of number of Americans dying every day. And just as a side note, maybe some of you might want to see, just to personalize that a little bit. There was a story on CNN today of a husband and wife in Texas who had 5 kids, 20 grandchildren. They both had COVID-19. They were both in the ICU, and their family and the doctors brought them together in the same room, and they were holding hands, and they died together on Sunday in Texas in the ICU. So this is still happening every day. So the vaccine is good, but there's a lot of work we have to do in the next few months outside the vaccine to reduce the number of events like that. Any questions about the statistics? Or any other questions, Steve?
Tiffany says, are cases added to 200K, or is it 200K new cases daily?
Could you say that again? I had a little trouble hearing you.
Oh, she was wondering, is the 200K cases added daily or cumulative?
That is number of cases per day right now in the United States over the past 7 days. That's an average. So like in the past 7 days, we've been averaging over 200,000. So another 1.4 million over the past week.
Yeah, great. Okay, thank you.
All right, so I'm just going to go back to the case briefly. Let me get this. So this is the 83-year-old woman we presented at the beginning. She went back to the hospital for fever, shortness of breath, and low oxygen. So she would count as a severe case, not critically ill, but needed to be in the hospital. She returned from the hospital after 4 days. She received this one medicine called remdesivir, which can help lessen the length of stay in the hospital, although not statistically shown to reduce mortality yet. She did not get any of the monoclonal antibodies or steroids. Her husband did test positive, largely because they live in the same household and have a lot of unprotected contact, but he only had mild symptoms. So the plan for someone like this is to stay isolated for 10 days from the start of illness. And then at that point, they're not considered contagious anymore. And CDC allows folks at that point to not stay in isolation. You contact, trace, and test any close contacts from at least 2 days before the start of symptoms. Do daily vital signs and oxygen checks to make sure that person's oxygen is not dropping, which is an early sign of respiratory problems. And then in this case, they had a personal care aide who gave daily support for her, used full PPE, had a negative test, and with PPE and kind of careful precautions, that aide was safe and stayed negative. Okay, so I'm going to talk about some of the good news now after the sobering stats about how difficult the environment still is in our country. There's 2, quote, mRNA vaccines. And I'm just going to highlight what are the keys for success of any type of vaccine, and then go into some details about the 2 that have been approved. I think as of today, the FDA is meeting as we speak to approve the second vaccine. The FDA said that you need to have both safety and effectiveness, and the safety they have required is at least 2 months after the vaccine is completed, after the second dose. You need to see 2 months of safety experience of the vaccine. So the studies ended basically in, I think it was early October, and now they've had 2 months of safety data since the second vaccines were given to the trial participants. It needs to be lasting immunity, preferably at least 1 year, and effective, meaning it reduces at least 70% of the potential infections. It needs to work in high risk and older persons, and not just in younger, healthier people. And it needs to prevent symptoms and serious illness. You don't want to just say, well, we can prevent transmission, but if it doesn't prevent serious illness, it's really not having a clinical benefit. So what's interesting about these two vaccines is they studied them, and they studied them about preventing symptomatic disease, but they have not been able to document that it prevents transmission. So this is a key point, which I want to have as a take-home point, Steve, for the whole group. We still need to wear masks for the next few months, because even if you get a vaccine, if you happen to have some COVID-19 in your nose or you inhale it, you might be a carrier briefly, and you can still transmit the disease. So it prevents symptoms, it reduces, transmission, but it may not prevent it as much as it prevents the disease, because they give you the injection in your shoulder, you get antibodies in your bloodstream. So if the virus gets into your system, you have protection. But it doesn't stop the virus from trying to reside in your nose. It probably reduces some symptoms of your respiratory tract in your nose, but it may not completely prevent transmission. And I think that I didn't understand that until I really read the studies. It's really about preventing symptomatic illness. So the great news was that on December 14th, people started getting the vaccine. The first one is Pfizer, the second one is Moderna. A lot of you have heard about these, focusing mainly on high-risk populations, healthcare workers, and ALF and nursing home residents. Wide access will probably be available in February through May of this coming year to the wider population. And there's a whole hierarchy, often like 15 different levels of types of people, and when they will distribute the vaccine to different groups. But I wanted to just show this table, because the study was published December 10th in the New England Journal of Medicine. You can find the details there. This is the Pfizer vaccine, but the Moderna vaccine had very similar numbers. There are two groups. They get 50% of them a placebo, and 50% of them, they give them the vaccine. There were about 21,700 in both groups. And they look for symptomatic COVID-19. So they did not study people for asymptomatic COVID-19. This was just for symptomatic COVID-19. And there were 8 cases in the vaccine group and 162 in the placebo group. So really remarkably effective vaccine for symptomatic illness. The number was severe disease, so ICU level care, really severe illness. There was only 1 in the vaccine group out of 21,700 people, and 9 in the placebo group. So those are small numbers. They didn't have the statistics to really say that's significant, although it looked significant. But the symptomatic, this 8 and 162, those two numbers are what got approval for this vaccine by the FDA and all over the world, actually, those two numbers. I'll stop there. Any questions about the vaccine or the mechanism?
Let's see. We got some questions that I think let's let you keep on going. They're back to the strain and testing and accuracy.
Okay, I'll keep going.
Okay.
So let's talk a little bit about kind of the holidays and prevention. And so obviously, I strongly encourage all of my patients and everyone who may be in a high risk category, especially right now, or a frontline worker, to get a vaccine, one of the 2 vaccines. I think they're both effective. But in the meantime, for the next few months, especially with gatherings of family, we need to be really careful about prevention. So the basic recommendations are small gatherings, less than 10, with just your immediate household and kind of known low-risk persons. Always continue to follow universal precautions. And the big 3 precautions are using a mask, physical distance, and hand hygiene. So you don't have to use a mask, obviously, if you know in your immediate household, you're in your kind of bubble. But if there's any people who are not inside your immediate family or have had an exposure that you know about, that's when you need to wear a mask. But if you have guests, you want to screen them for symptoms. Do they live or work in a high risk area? Have they had a recent test that's either positive or negative? And then I want to just close this about the holidays, and because I get this question a lot about mental and emotional health, and there has been a dramatic effect on the mental and emotional health of our country, both individuals, communities, from this pandemic, from the isolation, from the illness itself, from the anxiety about the illness. And the things that we can all do to help with our mental and emotional health are basic, but I think really important. And that's number 1, to stay active with your daily routines, with your social contacts, with outdoor activities. I the second bullet is what I kind of personally try to think about in my daily life, is to exercise, do something for others. And we actually really enjoy cooking together. You know, in your small group, it's a creative and kind of fun thing to do that it can get your mind off of some of the stress and anxiety of these times. There's obviously other habits that everyone has, and I encourage you to just think about what is your daily routine to kind of maintain your emotional health, and to talk about it, to talk about how hard this is and how stressful it can be. I'll stop there. Steve, is there any other questions kind of relevant to this discussion?
Let's see here. Well, here, let's just address a couple of these. And this is, I did see one, it talked about a new strain of COVID-19. Have you heard anything about that?
Yeah, I just briefly saw that story this morning that I think it was in England. They thought there might be a slightly variant of COVID-19. You know, I don't know much more than that. I will say that there's been some mutations in COVID-19 over the past 9 to 10 months, and some of the evidence suggests it's become more contagious, potentially a little less lethal, but as you can tell from the mortality data, it still is highly serious. But there is some evidence that the strain that came over actually from Italy and Europe was slightly more contagious than the one that was in China originally.
Great. And then let's see, Tyrus asks, can you speak to the accuracy and usefulness of the antibody tests?
Right, so the antibody test, I would say it can reflect that you've had exposure to the virus, but the antibodies drift down over time. So if you have a negative antibody test, say after 60 or 90 days, it doesn't mean you did not have COVID-19. The antibodies fade away over time. The good news is that there's another type of immunity that humans have called T cells. And the T cells are kind of this memory cells, and they remember the virus. They're not antibodies. And if the virus comes back, those T cells activate and they create a lot of antibodies and kind of kill off the virus. So the antibody is, I would say, it kind of reflects exposure in the last 90 days, but it can not very reliable as far as we know thereafter. And it doesn't mean you're sick from the disease. It just means at some point you have been exposed to it.
And Tyrus also asks, is there any reason for somebody who's already recovered from COVID-19 to get the vaccine?
Yeah, a common question. Ultimately, the short answer is yes, because the immunity can decrease over time from having had COVID-19, especially after 90 days. And the vaccine gives you a boost to help prevent symptomatic disease or kind of, especially if you got a large dose of the virus or you're in a high risk group. So we are recommending, especially if it's more than 90 days after people have had it, that they get the vaccine.
And then let's see, Monica asks, can you talk about the ingredients in the vaccines that some people might be allergic to?
Yeah, I actually just looked at the consent form. Actually, I'm actually lined up to get a vaccine on this coming weekend due to my kind of healthcare work. And the consent form describes the different elements in the vaccine. Obviously, there's the mRNA virus, which people are unlikely to be allergic to. I mean, it's not the virus itself, it's the mRNA fragment that creates a protein. But there are lipids that are surrounding that mRNA. And if people have some sort of reaction to these kind of something called polyethylene glycol, I just was reading about the allergic reaction someone had in Alaska, and the suspicion is that it might be the polyethylene glycol that was used to create that lipid layer around the vaccine mRNA. There's not a lot of other ingredients in the vaccine liquid, because it's a lipid covered mRNA fragment. That being said, we've only had the vaccine out for 4 or 5 months in the trials, and we don't have a long-term survey, so there are going to be side effects and reactions to the vaccine. I think the vast benefit of stopping the pandemic, as you could see from what happened yesterday in our country, I think is worth everyone taking it. But there are going to be probably unknown side effects that are very, very rare, but we'll probably see a few.
Great. We got a few more questions and I promise we'll get to them, but I'm really eager to you to get through your program and share some of the what's going on at Capital Caring Health.
Yes, let's talk about Capital Caring Health a little bit. So we have a variety of services. One of the geriatric services we've started with is called Primary Care at Home, or PCH. We have a team in Northern Virginia and Northwest DC and Chevy Chase. We have a wonderful staff, including doctors, nurse practitioners, social workers. I think Deanna Cho is on the call today as one of our social workers, office coordinators, and the whole team at Capital Caring Health, after hours team that helps us run the program. It's basically home-based primary and urgent care for elders. We are the primary care team, and the team is listed here as I said. Our mission is to coordinate all the care a patient and elder may need and their family may need over time until the last day of life. We coordinate their medications, their specialists, their DME, their social services. If they need skilled home health, we will arrange that. If they need to be in the hospital or have rehab, we coordinate those services. And if they're near the end of life, we offer hospice, but we provide comfort and dignity to folks when they're near the end of life. I think a hallmark of our program is we offer 24/7 kind of live access to nurse practitioner or nursing or the doctor if needed after hours, so that people can avoid 911 and avoid going to the hospital unless it's absolutely necessary. So I'm just going to give a brief update, and Steve, you mentioned this at the beginning, because I talked to you all probably last January when we just were kicking it off, just before the pandemic hit. In DC and Maryland, we have 6 zip codes that we serve. Right now, we have about 80 patients active in the DC Maryland team, and we have a capacity probably of at least 150 for the current staff that we have. Northern Virginia, we have 14 zip codes, a little larger area. We have about 50 patients with that team, also a capacity of up to about 150. And then we are expanding our Northern Virginia area in particular, and also potentially in DC with a new Medicare program called Direct Contracting. So I'm going to talk about that in a minute, but any questions about the primary care at home service or Capital Caring Health?
Yeah, actually, let's see. We got a bunch. And number one, I really appreciate you being so transparent and kind of sharing, you know, how many patients you have and everything. And it's we're really eager to see you get to those numbers that can expand the zip codes even more. But let's see. Okay. Cedar asks, have you expanded to Alexandria City yet?
Yeah, so just in the very near future, we have a nurse practitioner that we're going to start helping to provide team support to do a primary care at home in that region. So the zip codes, I don't have all the new zip codes off the top of my head, but I'll give you our phone number at the end, and you can call us. And we have 4 palliative care NPs who are going to now start doing primary care at home as well. And Alexandria, I think some of it is covered in that expansion.
Okay, and I will make sure that everybody gets all these zip codes, but off the top of your head, Bree Baldwin was wondering, do you do the 20009? I'm assuming that's Arlington zip code.
20009 is in DC.
Yeah.
And actually, we are not in that zip code right now. You know, my old house call program at Washington Hospital Center is in that, serves that zip code. They have a great team who I admire and are still doing good work. So the Washington Hospital Center house call team serves 20009.
And actually, I'm going to cut and paste all the zip codes into chat because I just found it on the website. So let's see. So Catherine Martin, that'll give you your 14 zip codes in Northern Virginia. And is the home-based primary care available in Loudoun County? I don't think it is yet.
Yeah, not quite yet. We're hoping to, again, expand to all of Capital Caring Health's regions. That is merely a matter of getting the staffing in place and finding a good financial model to support that kind of expansion. And it's probably a good segue to talk about direct contracting. I do want to mention this program.
Absolutely,
This is a new Medicare program that came out of CMS in 2020, and we actually applied and were named a provider for this program. It's a new payment model out of Medicare that is trying to promote comprehensive primary care for kind of high needs populations. That's the track that we applied for. It will officially kick off on April 2021, but we're doing all the preparation work right now. You can think of it as a kind of trying to encourage better care for those with advanced illness. And a typical patient, and again, this is one of hundreds of types of high needs patients, but this is like, you can think of a 90-year-old who has heart failure, congestive heart failure, which is CHF, dementia, a stroke, breast cancer, and kidney disease. You know, pretty common type of very elderly person with multiple chronic illnesses. What are the benefits for that patient if they get into this kind of direct contracting program with Capital Caring Health or another provider who participates? They get coordinated care is really promoted by the payment model by a primary care team, and it can be in the office. We happen to do most of our primary care at home, but you can also do this out of office settings. We have waivers with Capital Caring Health, again, starting in 2021, where we get easier access for our patients to inpatient rehab. So instead of having to go to the hospital in order to get to a rehab center, we can have people go directly to a preferred partner who does inpatient rehab. You can get easier access to skilled home nursing and minimize this, and skilled home PT and OT. You don't have to be homebound through this program in order to get skilled home nursing or PT and OT. And we can order those services easier than if people are not in this program. The key payment change for the provider is, instead of getting paid fee for service, like you get paid for each visit that you do, we get a monthly payment per patient. So we'll get like a fixed amount, say $150 per patient per month. And then we also get a share of any total cost savings. So if we keep people out of the hospital with this better care, we can share in cost savings from Medicare. And finally, just to kind of highlight the network we are part of, Capital Caring Health helped create and is a kind of a proud partner in this we call it Advanced Illness Partners is the name. And we're in 6 states and Washington, D.C. So this is a network of 7 actually providers, nonprofit, some hospice, some just advanced illness, but all folks who are committed to serving people with advanced illness in 6 states and Washington, D.C. And you can see the names of the folks down at the bottom. I won't read them all, but these are people from around the country. It's kind of fascinating. They're in Arizona, Florida, Washington, D.C., Virginia, Ohio, Nevada, and Oregon. These are groups that have had 30, 40 years each of experience in caring for people with advanced chronic illness, mostly through home-based and community-oriented primary care. And we're just, again, kicking this off as a national network, but we're doing the local work here in Virginia and Washington, D.C. Interestingly, patients in Maryland are not eligible for the Medicare Direct Contracting Program because Maryland has a separate total cost of care payment system. They're the only state in the whole United States that has their own Medicare payment system. And so they're not able to participate in the Medicare Direct Contracting. So this is for us, for Virginia and DC patients, but we still serve Maryland. They just are not able to be in this Medicare model. Before I go on, any questions about direct contracting? And I'll give you our phone number, and folks can call, and if they want to have us be their main provider of primary care, they can participate in this.
Yeah, and I've been trying to cut and paste your website and contact information. I found the Advanced Illness Partners site and posted that in there. Let's see. I think we primarily have just general questions that we can use our remaining time to answer. Is that
sure,
okay?
I have here the 1-800 number if you have questions about our service area, or you want to just look at the website and find out more about it. And this is the team of people. This is probably the most important slide I have here. We have one new doctor whose picture is not on this slide, Dr. Pallavi Dodakashi, who joined us a few months ago. But you can see the folks on our team. This is our mix of docs, nurse practitioners, a nurse, social workers, and administrators. Go ahead, Steve.
Yeah. Okay. Let me run through these questions here. And all right. So Susan Bloom asks, after 2 shots of the vaccine, will there be a need for a yearly vaccine as there is with the flu?
Yeah, it's a great question. I think the answer is we don't know for sure. If you look at other coronaviruses, the immunity tends to decline after 1 to 2 years. So I think that's remains to be determined. If I had to guess or make my best educated guess, I would say it's not a lifelong vaccine. There's very few vaccines that are lifelong. And so it's likely that we would need a recurrent vaccine, either 1, 2, 3 years. We don't know how long it's going to last, but they'll be studying that very carefully.
I know that this is a question on a lot of people's minds. Do you know that this vaccine would be 100% safe for people with underlying conditions and not compound their medical conditions?
Yeah. I think we can't say 100% safe. I think what we can say is that, as you saw in the data I gave, there were 22,000 people given the vaccine in the Pfizer study and a similar number in the Moderna study. In those 20,000 in each group that got the vaccine, there were no deaths. They had a lot of elderly people, to their credit, people of different races, both Black, Latino, white, and they had allergic reactions, a very small number. They had headaches and fevers, but they did include people with serious illness because that's who are at highest risk. So I would say the vast majority of folks with serious illness would have much more benefit from this vaccine than risk, but we can't say it's a zero risk.
Great. And Robert Massey asks, should people test before travel? And if so, is it true that many states and countries are requiring a negative COVID PCR or antigen test within 72 hours of travel, but many labs are booked and taking 3 to 5 days to get the results?
Right. Robert asked a great question. Thanks, Robert. So I'll answer the second part first. Yes, many countries and states are requiring documentation of a test result done within 72 hours. Yet, at least in our country, for common lay people, it may be hard to get a test result done in 3 days. So you're kind of stuck. There are a number of other airlines and travel kind of companies who are offering more expedited test results. So if people are traveling to outside the United States, having that test result in the 2 or 3 days before is often required right now. The other question Robert asked was, should you get a test before you travel? And I would say that in general, the answer to that is no, unless it's required. I think the most important thing you can do before you travel is to maintain these universal precautions of mask use and physical distance and hand hygiene. And if you don't have symptoms and you haven't had a high risk contact, I don't think there's a need to test before any kind of travel. I want to highlight that there's an incredible study done by an airline that flew from the United Arab Emirates to Singapore, and they studied 2,000 people who flew on an 8-hour flight in the midst of the pandemic. And they actually found that there were about 57 people who had COVID-19 of that 2,000. But what they found is that there were 0 transmissions on the airplane because they use universal precautions. They use masks, ventilation, and physical distance. And it's much more powerful to focus on the precautions than on kind of just high frequency testing.
Great. And Tiffany asks, and I think this applies to the Medicare program, what are the eligibility requirements?
So for Capital Caring Health's primary care at home program, it's for us it's 65 plus, so we are serving a geriatric population. The Medicare Direct Contracting, they just all you have to do is be willing to say this provider is my main provider of choice, and they're going to be my primary care provider and provide the majority of my care. To be eligible for the high needs population, though, it's a really important question. They have to have significant serious illness. So there's something called the HCC score, where basically they add up scores and points. You get points for every illness you have or how serious it is. So someone with heart failure, kidney disease, dementia, you have multiple serious illnesses, your score kind of approaches the level of 3.0, which gets you qualified for direct contracting. So not all of our house call patients are eligible. We have some patients who aren't as sick. They might just be immobile. And so I would say we're thinking right now about 30% of our primary care at home practice will be probably eligible for direct contracting.
Okay. And Barbara Sullivan just asked, who is next in line for the shots after first responders, seniors in institutional settings, and healthcare workers? And how do you find out if you're eligible to, or if you could be considered high risk?
Yeah, so it's different for every state. Every state is allowed to create a different rank list. So I would just suggest you kind of contact your Department of Health. There's probably a website for each state right now about how they've decided to rank them. Every state has committees, and they're different in each state. So I don't want to kind of tell you who's number 4, 5, and 6 on the list, because it will be different depending on which state you're in.
Okay, and I think what I am going to do, we've tons of complimentary comments in chat. I especially like the one from Catherine, who says that her mom joined Capital Caring in February 2020 and then came out with double pneumonia in April and used the home hospice, and how excellent that care has been. And she's thriving at age 96, and her family is very pleased. What I'm going to do, because we're nearing the top, well, we're past the top of the hour, and Carol Clark typed in a question earlier, but I think it would be better, Carol, if you ask that. So I see your hand is raised, and
Steve,
Carol,
I am going to have to jump off because I have another engagement to go to.
Okay, so let's wrap things up. Dr. DeYoung, thanks so much for coming on, and I'll share your PowerPoint, contact information, and a recording with everybody in the audience.
Thanks, and everybody stay safe, and hope you get the vaccine as soon as possible.
Okay, thanks.